Okay, in this video we're going to start looking at lower respiratory tract disorders. We need to look at acute bronchitis and pneumonia. Then we'll look at asthma, bronchiectasis, atelectasis, chronic bronchitis, emphysema, and lung cancer. So first let's start with acute bronchitis. This would be acute inflammation of the bronchi. It can also be inflammation of the bronchioles, and that would be acute bronchiolitis. That's going to be a little bit more ominous because the bronchioles, remember, are about 0.5 millimeter in diameter, and they're very susceptible to becoming vasoconstricted or bronchoconstricted, and so that can decrease airflow through them. Only about 5 to 10% of cases of acute bronchitis are associated with bacteria. The majority are viral. So although it sounds bad, person's hacking, they got all this mucus, it's most typically viral. They can also occur as exposure to toxins or fumes, like house fire fumes, if you work in a chemical factory, chlorine, ammonia, those kinds of things. That can actually trigger an acute bronchitis. And that one's more ominous because that actually, what happens is the acute exposure creates an immediate irritation and inflammatory reaction. But then over the next 12 to 24 hours, as the immune system migrates into the airways to try to heal that, it can create a very massive discharge of cytokines, which can cause complete bronchoconstriction, and that can result in acute respiratory distress. Cough, sputum production, shortness of breath, wheezing, less commonly fever and chest pains are going to be classic symptoms of acute bronchitis. Bronchiolitis is usually occurring more in children, usually under 2, so usually between 3 and 6 months. They get coughing, wheezing, shortness of breath, and this one is, again, you might see like that tripod position, the real signs of respiratory distress, and this may require hospitalization. Usually this is due to what's called respiratory syncytial virus, RSV, and it's going to be more common in winter months. That's spread in like daycare facilities, things like that. And the treatment is usually supportive, giving bronchodilators and lots of fluids. But again, that might require hospitalization for a deeper level of care. So classic agents that cause acute bronchitis would be influenza, we've already talked about as a upper respiratory tract infection. Adenovirus, this often causes serious inflammation of the bronchioles, and unfortunately this one is associated with that obliterative bronchiolitis, the popcorn lung, which again I talked about in conjunction of vaping, but adenovirus can also induce this, and this can result in severe narrowing or even obliteration of the airway lumen. So essentially ventilation stops, and that could be fatal. Respiratory syncytial virus, again, very commonly associated with the bronchiolitis, epidemics in nurseries, daycares, things like that. Fortunately, most of these cases are self-limited, and this is just something we want to look out for, any deterioration in respiratory function. Measles once was a big cause of bronchiolitis, now not as common because of the immunizations. Still, there are cases of measles, bronchiolitis, but also pneumonia. And that's one of, when people say they die from the measles, that's often one of the immediate reasons for why they die. Pertussis, that's the whooping cough. We've already talked about that. That can also cause bronchitis, bronchiolitis, but typically it's causing the laryngeal tracheitis. And then Haemophilus influenza, Streptococcus pneumonia. These can be involved in severe exacerbations. And then Candida albicans, that's a fungus or yeast, and that actually is going to be more, again, in immunocompromised patients and so forth. Now, the thing about acute bronchitis, especially in community settings, is we kind of diagnose it clinically. Generally, there's no need to do sputum cultures or anything along those lines. The assessment is usually physical exam, so showing decreased intensity of breath sounds. Wheezing, rhonchi, remember that's the sound of the bronchial breath sounds, versus rales, which are the crackles from the alveoli opening. Prolonged expiration and persistent cough. Chest x-ray might actually reveal hyperinflation, but there should be no evidence of pneumonia. So very severe bronchitis, I'm usually referring for a chest x-ray, and for if you don't have access to that, I would refer to someone that can do that to rule out pneumonia. Again, sputum sample is not commonly done. and then a complete blood count might just show that there's an infection by showing elevated white cells. Most of these cases are non-bacterial, they're viral, they're self-limited, and so you just need supportive care. Really, the guidelines suggest that acute bronchitis should not be treated with antibiotics unless there's a fever or acute symptoms are present, or after 10 days, if it keeps going on, they still aren't better, then it might be worthwhile doing a round of antibiotics. Smoking cessation, antihistamines can also be recommendations there. If it hasn't resolved within 4 weeks, that's usually when we do further workup. We're going to be more suspicious about, is there really just asthma going on here, or is there something worse like TB? Very rare, but something to always keep in mind. So that is acute bronchitis. The take home there is very common. Most cases are viral, most cases are self-limiting, but just be on the lookout for deterioration in respiratory function. Now, pneumonia is one of our major red flag things here. So pneumonia is going to be infection of the distal airways, usually the alveoli, with the formation of inflammatory exudates, which fill up those alveolar spaces. And this was going to be so concerning because it's going to affect directly the respiratory zone in the lungs. It's classified as either primary or secondary. In other words, does it start in the lung, or does it start from some other reason, some other situation in the body, medical condition and so forth. We can also classify it as bacterial or viral or fungal or other, like mycoplasma, that can cause so-called walking pneumonia. The bacterial causes are the most common with pneumonia, versus with bronchitis, it's most typically virus. And we can also classify pneumonia by the anatomical pattern. So some pneumonias, like the classic streptococcal pneumonia, creates what's called lobar pneumonia. So it affects only one lobe of one lung. So remember, there's 3 lobes in the right lung, 2 lobes in the left. So in lobar pneumonia, only one lobe, maybe 2 will be infected. All the others will be okay. Versus more diffuse pneumonia, bronchopneumonia is going to be around the bronchi, all over the lungs. And so you can classify, and that's going to be apparent on physical exam and chest x-ray, gives you that diagnosis. But now we usually use just the following method, which is to classify pneumonia based on if it's community acquired. In other words, you just got it out in the public. Did you get it in a hospital, including if you were hospitalized for surgery and you got it after that? Did you get it in the nursing home, or are you immunocompromised, like you have HIV, maybe full-blown AIDS? So the reason for this is that we know that different organisms infect these 4 different cases differently, and they're all going to need different treatments. So obviously the hospital-acquired, immunocompromised, you're going to need more aggressive treatment, more heavy-hitting antimicrobials than the community-acquired. The classic symptoms of pneumonia will be cough, dyspnea, and chest pain. So typically it's going to be a productive cough in older children and adults, but in younger kids it's going to be dry, and also in the elderly, very dry and productive. Dyspnea typically is mild and exertional, and it's rarely present at rest. So it's just when you get up and move around, you have dyspnea. And then chest pain can be pleuritic, can be located adjacent to the infected area in the lung, and it can actually manifest as upper abdominal pain and then the lower lobe is infected and irritates the diaphragm. In the elderly, it's going to present differently. So it can manifest with only mild or really confusing symptoms. There can be a possible change in mental status, so like confusion and restlessness and irritability. And then the fever is often absent in the elderly. Some of the classic clinical signs that we see would be fever with tachypnea, so respirations greater than 30 breaths per minute, and tachycardia greater than 110 beats per minute. The crackles or ralls on the lungs, bronchial breath sounds, agophony suggesting consolidation, again, dullness to percussion suggesting consolidation, and then the use of accessory muscles, what we call nasal flaring. You really see their nostrils breathing heavily, and then cyanosis, and that's going to be more common in infants and going to be more ominous in terms of the potential for respiratory failure. Some facts: an estimated 2 to 3 million people in the U.S. develop pneumonia each year, and about 45,000 die from pneumonia. So this is often the illness that a lot of elderly patients die from immediately, but they might have other health issues, heart failure, cancer and whatnot, and it's the pneumonia that actually is the final thing that they die from. It's the most common fatal hospital-acquired infection and most common overall cause of death in developing countries. The specific pathogens causing pneumonia are not found in over 50% of patients. So that's interesting, even with extensive diagnostic investigations. So people like, oh, there should be certain bacteria here. You keep getting their sputum and everything, and nothing is detected. So here again, we can kind of think of a salutogenic model, which suggests that the pathogens are probably actually there already in most people. And it's just that there's now a change in the respiratory terrain, making them more susceptible to those pathogens. And so that's why as we get older, our immune systems fail, especially if there's other health issues going on, maybe immunosuppressive medication, you're going to be much more susceptible to that. The bacteria and viruses are the most common agents. Fungi and parasites can also cause pneumonia, but they're going to be less common. Some of the most common bacteria would be Streptococcus pneumonia. That's about half of cases. And they're very common drug-resistant forms now. So something called drug-resistant Streptococcus pneumonia, DRSP. And we don't hear about that one in the media, but that is actually going to be resistant to all known current antibiotics. Haemophilus influenza, about 20%. Chlamydia pneumonia, about 13%. Mycoplasma, about 3%. And then less commonly Staph aureus, Moraxella, Legionella, and other gram-negative bacteria. In terms of viruses, RSV, adenovirus, rhinovirus, influenza, and some others. So those are the most common kind of infectious agents. But again, we typically are not going to go searching for those, and we're going to kind of classify people on those 4 categories of community-acquired or elsewhere. So here's just a picture showing the alveoli and how the pus and fluid really fill up the lungs in pneumonia. So if a patient presents to your office with all the classic signs of pneumonia, the cough, the dyspnea, the chest pain, they got fever, they have the rapid respirations of over 30 and the rapid heart rate over 110, and you suspect that, they really need a chest x-ray. And so that's going to be the next kind of diagnostic workup. Now, if they're in the emergency room, they can get that done right away. If they're in your outpatient office, in your PCP, then you're going to have to wait for that. But that's going to tell us specifically if there are any sign of pulmonary infiltrates. And they're usually going to be absent in the first day or 2 of infection, but then they'll be present after that. Our physical exam, that's going to be important to do to check for any very low blood pressure, again, the high heart rate, low oxygen saturation, high respiratory rate, the rhonchi and rales. Rales going to be more common, the crackles, and then doing the percussion and auscultation, indicating any consolidation. So generally, there's no specific findings to distinguish one type of infective agent from another, but typically, strep pneumonia or Legionella will give you lobar infiltrates, so it'll affect a single lobe. Whereas interstitial pneumonia suggests more of a viral pathology, or mycoplasma. Mycoplasma are weird. They're sort of like bacteria. They're much smaller. They don't have the classic cell walls of bacteria, and they actually can get inside of cells, versus most bacteria live outside of cells. So they're intracellular. And this is what can cause interstitial pneumonia. It kind of infects all the interstitial spaces of the lungs. And this is what causes the classic, what we call walking pneumonia, where people now walk around for this, come up with the low-grade pneumonia symptoms for weeks or months. Again, usually we differentiate into the community-acquired versus others, and that's going to tell us what kind of therapy to use. Now, it can be challenging. There are a couple of scales that can help us in the clinic to decide if this is pneumonia. So again, temperature over 37.8 degrees Celsius, heart rate of over 100 beats per minute, crackles on auscultation, decreased breath sounds, and then absence of asthma. And so if there's a score of 0 to 1, that's a very low probability, but if you get up to 4 to 5, you have a very high probability that this is pneumonia. In the hospital, the patients are given more thorough workup. They actually do sputum cultures, they look at their blood counts and everything else. Now, most cases usually improve within a day or two with the proper treatment. And that's typically going to be oral antibiotics, rest, simple analgesics, fluids. Hospital patients are going to need a lot higher level of care, and especially infants, children, and elderly are going to need a lot more care. And that's why the sort of mortality rate in hospital patients is actually about 12%. So that's fairly high. And the complications going to be things like empyema, which is an abscess that forms in the lung, bronchiolitis obliterans, that's where the bronchioles become obliterated, there's no airflow, acute respiratory distress sepsis, which is basically a blood infection, and that can create shock systemically. So it's always a important thing to understand with your patient, do I need to have this patient hospitalized with pneumonia or not? And if you have no idea, if you're not a primary care doctor or can't make that decision, then refer. And this usually patient doesn't need an ambulance, but they need to be taken to the emergency room unless they're in acute respiratory distress. Then they need the ambulance. So we're going to do first a risk stratification, look for red flags, children, elderly, any comorbidities, immune status. Again, does the hospital need referral and hospitalization? Another tool, but this requires some blood work, which might not be available to you, is called the CURB 65. And if the score is higher than 2, that indicates hospitalization. So you might want to look through that. There's only one blood test, and that's urea. The rest of them are clinical things. And so you can kind of, again, get a kind of sense of, okay, this patient really needs to be transported to the hospital. Typically, antibiotics are given. In outpatient, we give things like azithromycin, erythromycin, or doxycycline. Doxy is commonly given in that, but azithromycin, you can actually get this as what's called a Z-Pack. It's a 5-day course. You take 250 milligrams twice on the first day, and then 250 milligrams for 4 days. So that's the typical treatment there. Antivirals for influenza and chickenpox virus could be used, but usually not. And then supportive measures are given. Now, this is always a question of, so the patient just wants herbal therapy instead of antibiotics. And that's really, if there is an indication for the antibiotics, especially if there's any of these more kind of red flag kind of symptoms, then it's, I think, really important for us to kind of discuss the therapeutic order, that we need to jump to level 4 and that we can work back to level 1 and 2, maybe as more supportive care, long-term care to prevent this from happening again, preventing residual problems, but they usually really need urgently that level 4 care. So that's an overview of pneumonia, so it gives you something to think about in terms of understanding when you might need to send that patient for further care. Okay, those were bronchitis, pneumonia. These are infective conditions of the lower airways. Now we're going to jump into chronic conditions of the lower airways. I'm going to start here with asthma, and then in subsequent videos I'll look at chronic bronchitis and some of the others. But in asthma, this is a chronic inflammatory disease of the airways. It affects a large proportion of the population, about 26 million persons in the US. It's the most common chronic disease in childhood. It has recurring symptoms, and importantly, we say that the airway constriction is reversible in asthma. In chronic bronchitis, we'll see it's not reversible. So that's one difference between asthma and chronic bronchitis. What happens is the constriction is easily triggered, so we get these bronchospasms, which create obstruction in the airway. Now, unfortunately, over time, there's a chronic inflammatory process that sets up in asthmatic patients, and that actually can lead to smooth muscle proliferation and chronic narrowing of the airways, and that's called airway remodeling. And this is why we find that just using a bronchodilator, as I mentioned before, is not enough. We actually have to do some anti-inflammatory support to prevent that from happening over time. Asthma is often worse at night, or with exercise, or after meals, and that's partly because of the increased parasympathetic responses during those times. And remember, parasympathetics really cause the airways to narrow. So if they're already mostly narrowed, then we start to get symptomatic from that. There are various triggers. So we talk about what are called exogenous or extrinsic factors, and that's the classic allergic or atopic asthma. And that's really after inhalation of different allergens, pollens, or so forth. Children with this often have what's called the atopic triad, and that's hay fever, eczema, and asthma. But there can also be intrinsic or endogenous factors, and that could be genetics, different medications, alcohol, medical factors. All these can trigger asthma as well. We're finding in the newer classifications, there's a crossover between these two. So really asthma is not just an extrinsic thing. There's really exogenous or endogenous factors here as well. The clinical symptoms, the classic ones are wheezing, usually on expiration. But in more severe asthma, it can be on inspiration. So don't let that, discourage you from making an appropriate diagnosis if you need to, or letting that confuse you. It can also occur without wheezing if the small airways are affected only. And it can be exacerbated again by exercise or at night. Coughing, that could be the only symptom of asthma. I have a number of patients who think they have just allergies as a cough, and we actually do some airway testing, and we diagnose them with asthma. It's often non-productive. It's paroxysmal, it just comes on at random times. And in children, the cough is again often worse at night. And then chest tightness, be another classic sign of asthma. And then shortness of breath with maybe increased respiratory rate. They can be using their accessory muscles of respiration. Now, in an asthma attack, we might even see cyanosis, pulse ox falling below 85%, and so forth. Now, one interesting feature of asthma is a paradoxical pulse, and that's a pulse that's weaker during inhalation. So you feel their pulse, you haven't breathed in, and the pulse actually weakens a little bit. That happens as well. Asthma attack, again, is an acute exacerbation, and so all these symptoms are going to be much more severe. And usually after the attack, there's going to be severe coughing. And they're actually going to cough out these crystals, Kirschmann spirals, which are mucus, crystallized mucus, eosinophils that are all mixed in there, and then what are called Charcot-Leyden crystals. So that's usually going to be after a severe asthma attack. And that shows you something about the nature of asthma, that it's more of a sclerotic hardening condition, and that's the kind of nature of a lot of these chronic lung diseases. Again, the lung becomes almost too head-like, which is going to start to take us a little bit into the idea of therapy, that people that are over-intellectual, that have a certain type of thinking process, maybe are more susceptible to asthma. That used to be an old way of thinking about it. Status asthmaticus is very severe. This is a severe acute asthma, unresponsive to therapy. So this requires hospitalization. They need to try all sorts of things, and unfortunately, a lot of times this is fatal. So status asthmaticus, that would be asthma unresponsive to the typical therapies. We classify asthma based on the frequency of symptoms, the spirometry results, the forced expiratory volume in 1 second, and the peak expiratory flow rate. And so we can classify it as intermediate, mild persistent, moderate persistent, or severe persistent. So those are some classic asthma classifications, and I'll go through that here because that'll be important for assessment and treatment. Now, the pathophysiology is complex. I'll just kind of summarize it here by saying there's 3 basic things that happen. There's the immediate airway inflammation, and that can be triggered again by endogenous or exogenous stimuli. There's an increase usually of the Th2 immune response with all your classic Th2 cytokines like IL-4, 5, 6, 9, and 13. The airways have increased macrophages, mast cells, and eosinophils, so these cells migrate into the airways. That creates airway edema, more mucus secretion, and then we get upregulation of leukotrienes and prostaglandins and histamine, which further worsens the inflammation. And so that's the first thing that happens, and that's actually going to cause bronchoconstriction. That's the next step here is the airway obstruction. Now, one theory we have out there is that the reason why this is becoming so common in children is the so-called hygiene hypothesis, that there's increased Th2 responses versus Th1 because kids are not as exposed to childhood infections like they once were. And interestingly, with immunization, although life-saving, we also have this problem of the immune system gets shifted over time into Th2 responses, and that could predispose one to asthma, as well as the other parts of that ectopic triad, or atopic triad, which would be asthma, eczema, and hay fever. But the airway obstruction would be bronchoconstriction, airway edema, we get the chronic mucus plugs. Now, over time, all those cytokines are going to activate fibroblasts that are in the airways. And remember, fibroblasts secrete collagen, but that's also going to stimulate smooth muscle hyperplasia. And that's part of that airway remodeling that I spoke about. And then over time, the bronchi become hypersensitive, and they just, any little stimulus will cause them to bronchoconstrict, and that can cause the lungs distal to that airway to become hyperinflated, but that creates hypoxia. And the early compensation is for hyperventilation, but then late stage, not enough exhalation of carbon dioxide. We get an increase of CO2 in the blood, and that results in respiratory acidosis, like we had talked about. So that's some of the pathophysiology behind asthma. For most of a person's life, we think, though, that the airway constriction and so forth, even if there's been some airway remodeling, is reversible. But with like status epilepticus, that's a person really where that's kind of showing us that no, that's not reversible at that point. Even with the bronchodilators, they can't adequately get their airways open. All right, so that's a little on the kind of clinical presentation and the pathophysiology of asthma. So in terms of definitive diagnosis of asthma, requires the symptoms we talked about. It requires the spirometry testing, often with what's called bronchoprovocation, where the person breathes in a certain agent, and that will actually cause bronchoconstriction in some people, and you can see if it actually triggers asthma, or a bronchodilator and see if that actually improves their airflow. Can also exclude other diagnoses. And there are different tools that can be used to assess asthma. So I'll talk about that, but basically we can look at the history, again, presence of a wheeze, cough, usually worse at night, shortness of breath, episodic symptoms, having characteristic triggers like the exercise, cold air, personal or family history of the atopy, and then history of asthmatic symptoms as a child. Now, less likely it's going to be asthma if there's lack of improvement from anti-asthma medications. In those patients, I start thinking about chronic bronchitis and not asthma, because in chronic bronchitis, technically it's not reversible with those medications. Onset of symptoms after the age of 50, concomitant symptoms like chest pain, syncope palpitations, or history of cigarette smoking. We're going to go and do deeper assessment and kind of think this is probably not asthma. This could be, COPD. This could be a lung cancer or something like that. Now, we can use pulse oximetry readings also to help us. Mild asthma is going to be 97% or higher. Moderate would be 92 to 97%. Severe is less than 92%. And again, the emergency is under 85. Now, what I often do is I'll have patients with asthma maybe walk up and down the stairs a couple of times, and then get their pulse ox after that, and we can see if they're able to compensate for that increased exercise demand. Physical exam is going to look at our vitals, pulse ox, respirations, pulse rate, wheezing, again on the lung auscultation, and looking for the presence of any atopic dermatitis. Pulmonary function tests would show a decreased FEV1 to FVC ratio, usually less than 0.7. And then reversibility with a bronchodilator. So they're given the spirometry, we see that decrease, we give them a bronchodilator, and all of it improves. The FEV1 increases. And then the peak expiratory flow rate can be used to monitor the activity. Other labs would be checking a CBC for anemia and eosinophilia, which is classic with allergies. Sputum might show increased eosinophils. That's not typically done. Chest x-ray is usually normal, maybe can show some hyperinflation. If the person's very severe, we might give them an EKG to make sure they're not having any cardiac arrhythmias that, for example, we couldn't use the asthma medications with. And then maybe skin allergy testing to check for atopy, and typically no further imaging like CT or MRI is needed. So our basic questions we're going to ask is, how severe is it, and do we need referral, and then determine the level of treatment. So here is the asthma severity scale for children above the age of 12 and adults. So we're going to look at these three classes here: intermittent, mild, moderate, or severe. And so basically, if they're having symptoms less than 2 days a week, they're having less than 2 times monthly awakenings, 2 times a month that they're waking at night, and then they are having to use their short-acting beta agonist, the SABA, less than 2 days per week. It's not interfering with normal activities, and in terms of lung function, they're having a normal FEV1 between any exacerbations and greater than 80% predicted FEV1 for lung function. Then we're going to classify them as intermittent asthma, and they're going to get step 1 therapy. I'll talk about what step 1 therapy is. Mild asthma is going to be symptoms greater than 2 days a week, but not daily. Nighttime awakenings 3 to 4 times a month, and then more than 2 days a week, but not daily, with their SABA. Minor limitations, and then some of the characteristic changes on spirometry there. They're going to get step 2 therapy. Moderate's going to be daily symptoms, awakening greater than 1 time a week, but not nightly. They're using their SABA daily. They have some limitation, and their lung function is even more compromised there. That's going to be moderate, needing what's called step 3 therapy. And severe is going to be throughout the day, waking up frequently during the night, using their inhaler several times per day, so forth. And that's going to need step 4 or step 5 therapy. So this is a very helpful little tool. You can find these tables online, and these can kind of help you predict how aggressive in terms of treatment does a patient, does a patient's protocol need to be. So these guidelines for asthma assessment and treatment come from the National Asthma Education and Prevention Program. It's an expert panel from 2007. And again, we determined the asthma severity: intermittent, mild persistent, moderate persistent, severe persistent, and then use the asthma steps for the appropriate level of care. And the goals really are to reduce the impairment by minimizing the use of the SABA to hopefully less than 2 days a week, with few nighttime awakenings, and to maintain normal activities, and to hopefully prevent any airway remodeling over time. So that's kind of what we think about doing there. Now, in terms of the asthma steps, again, we just went through the assessment there, but the step 1 treatment is going to be a SABA as needed. That's PRN. Step 2 would be a low-dose inhaled corticosteroid. And then these alternative treatments like the cromolyn, like the leukotriene antagonist, and so forth. Step 3 would be a low-dose inhaled corticosteroid with a LABA, long-acting beta agonist, or a medium-dose inhaled corticosteroid. Step 4, we're jumping up to medium-dose inhaled corticosteroid with the LABA, and then high-dose in step 5. And with step 6, this is going to be high-dose inhaled corticosteroid, LABA, and oral corticosteroid. So that would be the biomedical approaches. So, the first thing I do with asthma in terms of the therapeutic order is I determine what step they need to be on. We initiate the proper level 4 therapies, and I do this as a PCP, but if you aren't a PCP, you might want to refer. And if it's very severe, maybe even referral to a pulmonologist might be necessary. But the medications would be, again, the beta agonists, SABAs, LABAs, glucocorticoids, and they're classified as low dose, medium, high dose, or oral agents. Leukotriene antagonists, and the others like the theophylline, mast cell stabilizers, and so forth. Now, the emergency treatment for asthma, just so you know what it is, this is what's usually done by the paramedics or in the ED. This would be epinephrine injected, oral hydrocortisone, and one of the first generation, like Benadryl or the chlorpheniramine antihistamines. So that's typically part of what people in an asthma attack might be given. And they might be given a nebulizer of the SABA as well. So that's the level 4 therapies. Once I have them appropriately treated on the asthma steps, then we can back up and work with looking at the lifestyle issues, diet, lifestyle, exercise, but in particular the level 2 therapies, and addressing their lung patterns. Now, very common, I see either a digestive pattern or a kidney G deficiency pattern, which would be low DHEA pattern in asthma patients. And I've had a number of pediatric asthma patients where the adaptogenic herbs, which really work to increase DHEA, like rhodiola, eleutherococcus, many of the panic species, schizandra, all of those herbs can actually have been very helpful for asthma. And I often add boswellia to that as a leukotriene antagonist. I sometimes will give that in conjunction with an acute acting formula that has more bronchodilators, like I actually use Kella, so it's a cromolyn. We can even use low dose the ephedrine, and there are a number of other herbs like mullein and horehound and elecampane, and these kind of herbs that we use more just to support the lung function directly. We can say the lung-kidney axis is a very important one, and sometimes the lung GI axis will be another to address with chronic asthma. So hopefully that gives you a little idea of maybe how to approach in an integrative manner asthma.